Hello and welcome. I'm your host, Neil Howard, here on Health Professional Radio. Thanks for joining us once again. Have in studio with us this morning, Dr. Daniel Cahill. He's presenting at the 2019 American Association of Neurological Surgeons Scientific Sessions, and he's joining us on the program to talk about some of the latest techniques that are being used to help surgeons at Mass General make substantial impacts on long-term prognosis of individuals with IDH1 mutant tumors. Thanks for joining us on the program today, Dr. Cahill.
Thank you very much for having me.
Now, I know that you're a neurosurgeon, scientist. Give us a bit of background about yourself and talk about this IDH1 mutant tumor.
Sure, absolutely. So I practice at Mass General, as you mentioned, and my real focus is on patients who have primary brain tumors. And over the last 10 years, there's been a major revolution in recognizing patients who have these tumors, being able to categorize them appropriately based on what diagnosis they have, what type of tumor they have. And there, in 2016, there has been a reclassification of the tumors that includes this molecular status or IDH status. There are two genes, IDH1 and IDH2, which categorize patients who have a real benefit from having aggressive surgery to help them live longer with that treatment. And we can identify them now that we know about these molecular subtypes.
So who is at risk of developing these specific types of tumors?
That's a good question. So we typically find these tumors in patients who range in age from about in their mid-20s to about their mid-40s. Although I have seen a very wide range of patients in my own personal practice. I've had patients as young as 11 years old all the way up to 89. So there is a broad range. However, it tends to be young adults, people who are entering the prime of their life, their early working years, early family years, just getting married or starting to have children. And so this is a major impact to get a diagnosis like this, that they have a brain tumor at that age. And it is very scary. And one of the things that's really very positive about the recent findings is that we can intervene in a way that really promotes or maximizes the chance for long-term survival in these patients. Patients really do seem to have a dramatic extension of survival in association with aggressive surgery in this subgroup.
What was the traditional outcome? What was done, and what was the longevity expectation there?
Right. So it is the best we can tell what happened in the past is based on historical data, which predates our knowledge about the IDH mutation, which was only discovered in 2008. So when we looked in clinical series of patients prior to that time, they were mixed, they were heterogeneous, and it was hard for us to pick out the specific subgroup of patients. So basically all patients would get sort of standard therapy, which was a surgical procedure, then radiation chemotherapy. And what we can recognize now from looking at sort of selected groups or cohorts that just have the IDH mutation is that the type of surgery has to be very specific. So it's resection of the standard resection, but then additional amounts of resection around the edges of the tumor. And what that means typically, or in many cases, is as you do that first surgery and then the patients find out they have the IDH mutant tumor, they often have to think about having a second surgery, or what is we refer to as a completion surgery, so that they can get to the best starting point before they then start follow-up with neuro-oncology and then consideration of the timing of other treatments.
So as far as recovering from the initial surgery, has that been reduced recently?
Yeah. So what happened? What I would say is that these patients have a lot of time to consider their options. So what will happen is they have their initial surgery, and in that first month or so of recovery, they find out that they have an IDH mutant tumor, and we can then reassess with a new viewpoint or a new, and in the next few months, plan a second surgery after things have renormalized from the first procedure. These patients tend to do extremely well in terms of neurologic outcome. They're typically functional, back to work, and back to their family lives and everything like that very, very soon after the initial surgery or the initial 2 surgeries, whatever anybody needs.
And as far as recurrence of the problems, are we talking complete recovery and, say, living into their 70s, or is the 50s once the diagnosis is made and the treatment is rendered? Are we talking 50s, early 50s, late 50s for survival? That's a key question. So we're really trying to learn as much as we can about that. So there are patients who have progressive disease, and this is a subset of the subset. So a percentage of patients who are IDH mutant, the vast majority of patients do very well. There is a subset that has progressive disease, and we're trying to understand how patients switch or have this more accelerated growth rate, and what we can do to stop it. So it is difficult for us to know really if we do the optimal treatment, what is the expected survival. We know it's very long, but we don't know what it is that then causes certain patients to switch into a more accelerated growth rate. Those patients then have a very difficult course, and they actually have a fatal course when they switch to an accelerated rate. But as I said, that's a percentage of the patients. So we're learning a lot about that. That's our current focus of research. Where can we go online and get some more information about this mutant tumor, and learn some more about what was going on in the past, and talk more about, learn more about the sessions that you were involved in?
Right. So I would say that, there's very good information at both the National Brain Tumor Society websites and the ABTA websites. And then also on our websites at Mass General. The Brain Tumor Center here is very comprehensive, and you can learn a lot of information about this new way of categorizing tumors, the WHO 2016 diagnostic criteria, and how that has impacted how we approach patients and in their initial phases of diagnosis, and how we make the diagnosis, and then how we plan their treatments afterwards. So,
well, Dr. Cahill, thanks for joining us on the program this morning.
Thank you so much for having me.
You've been listening to Health Professional Radio. Transcripts and audio of this program are available at hpr.fm and healthprofessionalradio.com.au. You can download and listen in on SoundCloud, and be sure and visit our affiliates page when you visit our platform at hpr.fm.
Thank you for listening to Health Professional Radio. We're very proud to be an independent broadcaster, providing our content free of charge to you, the listener. One of the ways that we're able to remain free and independent is by having people like you become patrons. You can support Health Professional Radio simply by visiting hpr.fm and clicking the button that says Become a Patron. Your patronage of even just $1 a month lets us know that you're there, which in turn makes us more valuable to advertisers. And, of course, if you're able to afford more, then we would certainly appreciate the support. My name is Toby Longhurst from Health Professional Radio. Please visit hpr.fm, click the Become a Patron button, and support us if you can.